Thank you for the panel. We have an excellent panel here. Dr. Ellisen is a professor of medicine at Harvard Medical School and the program director for breast medical oncology at MGH. He's the co-leader of the breast cancer program at Dana-Farber Harvard Cancer Center. His personal clinical practice is focused on cancer risk assessment, and he leads our genetic clinic at MGH in breast cancer. And his lab is focused on revolutionizing cancer treatment through personalized cancer treatment with a particular focus on triple-negative breast cancer and TP53. Dr. Darrell Borger is the co-director of the Translational Research Lab at MGH. He was instrumental in developing the snapshot tumor genotyping technology at MGH and leads our biomarker efforts for trials where we partner with industry. Justin Gainor is an attending physician in thoracic oncology at MGH. He's involved in leading clinical trials, particularly related to immunotherapy and immunotherapy combinations. He's also the MGH principal investigator of the Stand Up to Cancer grant, focusing on targeting KRAS in lung cancer through immunotherapy and targeted therapy combination. So we have a wonderful panel here, and we thought we'll discuss two cases. So I'll start with the first case. The first case is of a 74-year-old female who had a remote history of breast cancer. 20 years ago, she was diagnosed with ER-positive breast cancer, had received standard chemotherapy followed by tamoxifen and aromatase inhibitor. In 2016, during a routine breast MRI, it was noted that she might have partial atelectasis of her right side of the lung. So this was worked up further with a CAT scan, which demonstrated a large hilar mass, underwent a bronchoscopy and biopsy of the lymph nodes, which demonstrated adenocarcinoma that was ER negative and consistent with a pulmonary primary. She also had routine restaging scans done, which demonstrated no evidence of brain mets, but demonstrated evidence of bone mets as well as pulmonary mets. So she was diagnosed with metastatic lung cancer. Her tumor was sent for genotyping, and the genotyping report showed an alteration in TP53, STAG2, NF1, FOXL2. She also had rapid EGFR and ALK FISH testing done, and that was negative. So I'll probably start here and start with Darrell. Darrell, do you want to comment on the genotyping results for this patient?
Yeah, so we have 4 different variants that were identified. All 4 of these are tumor suppressors. So maybe just kind of go down the list of what was found. So P53, no introduction needed for P53. Obviously a primary tumor suppressor gene, mutated in half of all cancers, including lung cancer. Very important, obviously, for DNA repair. The mutation that we see here, arginine 181 proline, this is a missense mutation, so these are the hardest for us. You know, we have to determine if this is deleterious or not, or if this is a passenger mutation. Fortunately for P53, there's some good databases that are available. The World Health Organization has a good one, the IARC, and so we would look there and find that this is in fact a deleterious mutation. So clearly a driver mechanism in this patient's tumor. In terms of lung cancer, P53 mutations are associated with worse prognosis, particularly in lower grades. I don't know how that pertains to this patient here, but then going down to STAG2. This is a gene that is part of the cohesion complex that's required for proper segregation of chromosomes during mitosis. And mutations are known to drive aneuploidy. We found a splice region intronic variant here, and this would be deleterious. So this is a region that's required for recognition of the intron-exon boundaries. And if you have a mutation there, what happens is you can have a lot of intronic sequence that gets put into that RNA, or you have a lot of skipping of exons. And so that gets incorporated into the protein, and you would have an abnormal protein in that respect. In terms of implications in lung cancer, there's really not a lot of information. Prevalence of mutations across cancers as a whole is about, I think, 5 to 15%. Lung cancer is pretty much right in the middle of that. Interestingly, though, based on this signature, if you look at Ewing sarcoma, which is a childhood malignancy, bone malignancy, co-alterations of STAG2 together with P53 actually suggest very poor prognosis. So this might be a signature of a very aggressive form of lung cancer. Then I'd probably jump down to the SMARCA4. That is the catalytic subunit of the SWI/SNF chromatin remodeling complex. So it's important for driving gene expression as well as DNA damage. We have a point mutation here. It's very rare in lung cancer to find these alterations, and this is a particularly rare variant here. So there's really no information as to what the clinical relevance of this might be. But there was a report, I think it was earlier this year, that showed at least reduced expression, RNA expression of SMARCA4 in lung cancer was associated with not just poor prognosis, so we have another prognostic indicator here, but then also potential response to chemotherapy. But we know based on the history that might not be the case. And then lastly, NF1, we have another splice region intronic variant, so we think that this is going to be relevant in this patient. NF1 is involved as a modulator of MAP kinase signaling. It is actually a negative modulator when it's intact, so mutation would lead to inactivation and drive the activity of a very important cancer signaling pathway. There's actually some crosstalk with another very important cancer pathway, the PI3K, AKT, mTOR pathway. So this would be actually, I think, a significant finding in this patient.
So when you have a tumor like this, which has multiple alterations and maybe multiple driver mutations, how do you distinguish clonal versus subclonal, driver versus passenger? Because this would have big implications for therapy.
Yeah, absolutely. It's tough. This is actually a tough case. You picked probably one of the tougher cases, being tumor suppressors. Unlike oncogenes, oncogenes are leading to constitutive activation, so it's really a small number of mutations that would drive that, and those are very well characterized. With tumor suppressors, you can inactivate the protein many, many different ways. So what we look for is mutations that clearly lead to dysfunction of the protein. So a mutation that would lead to a nonsense mutation, introduction of a stop codon, where you'd have a truncated protein. A frame shift where all the coding gets shifted. Usually what happens is you have a premature stop codon that gets introduced there. Splice site mutations we talked about. But it's really the missense mutations that are difficult to really determine. Those are 80% of the mutations that we find. And so it's a painstaking process. I mean, everyone is on a case-by-case basis. We have to go into the literature. We probably start off going through some of the resources like the Cancer Genome Atlas and COSMIC to look at the frequency of these alterations that have been reported in cancer. Try to get some insight there. There's some predictions in terms of whether or not it's deleterious or not. But ultimately, we go into ClinVar that might have some some information as to its clinical relevance. But usually we're going into PubMed on a case-by-case basis and looking for information as to the biological implications of that mutation. And if we're lucky, we'll get some information on therapeutic implications. So it can be difficult. It can take a lot of time. In terms of heterogeneity, what we look at is we actually look at the allelic frequency of that mutation and look at the sample that we tested in terms of the tumor cellularity. So if we had a tumor that was 50%, we had a tissue that was 50% tumor, we did testing and we found an allelic frequency of 10% for a mutation, we would suggest that that was probably indication of heterogeneity. Sometimes we'll actually find mutations, concurrent mutations in the same gene at low allelic frequency, which would, again, indicate heterogeneity. Those are some of the things that we look at.
Sort of explain that allelic frequency and the importance of that. For example, in this case, if we have 4 mutations, if allelic frequency is higher for one of the mutations, does does that indicate that it's more likely to be a driver?
Yeah, I think absolutely. So the idea is that, of course, a driver mutation is going to be in the founder clone. And so all clones that are derived from that will still have that underlying mutation. And so as Bruce mentioned, when we do sequencing, we have a readout in terms of how many reads had a mutation versus all the reads for that run. And that will give us an allelic frequency. And when we're looking at tumor suppressors, it's a little bit complex because there could be loss of heterozygosity in terms of what that allelic frequency will be. But the idea is that if you have a 50% tumor and your allelic frequency is 50%, you probably have a loss of heterozygosity event in a tumor suppressor and then a mutation that's found across pretty much all the clones in that tumor.
So you've lost the normal allele.
Correct.
And then since it's 50% that have the mutant allele, and it's 50% of the cells are tumor, virtually every tumor cell, at least you can presume it's in the tumor cell that they have that mutation.
But then there's also the scenario, though, in that same context where you might find the mutation at 25%.
Yes.
So half. So there's probably likely another mechanism that silenced the other allele. And so that would be consistent also with in 100%.
So what is the sort of baseline for allelic frequency that you use as saying this is actually likely to be important? Does it vary with genes and with the...
It's kind of a toolbox approach. I think that we really try to assimilate as much information as possible to really try to understand the potential clinical impact of these variants. So allelic frequency is just really one aspect of that. If we find, like I said, if there's like an 80%, a sample with 80% tumor, and then we find something at a 5% allelic frequency, more than likely that occurred late in evolution of that tumor. It's not really an underlying founder mutation. We would probably weigh that a little bit less than something that was in the vast majority of those tumor cells.
That's a great point. And I'm sure this gets also complicated by aneuploidy and other alterations that a tumor cell might possess.
Absolutely.
Leif, can you comment on TP53? What does the TP53 alteration signify in terms of functional consequence and consequence on the cellular signaling, and also some potential strategies to target TP53?
Thank you, Aditya. I think I'd maybe like to first take a step back, and Darrell has given a great perspective from the molecular pathologist about synthesizing data and interpreting reports. But ultimately, of course, the goal of the report is to make it interpretable for the oncologist. And it's a shame the audience can't see the report because one of the most critical factors for the molecular pathologist is to synthesize the data to the degree that oncologist knows whether the findings are truly actionable in the clinical setting or not. And for example, the variants that are found in this case, none of them would really rise to the top 2 or 3 tiers of what would be considered clinically actionable. And so this is a good case of where very interesting variants are found, but one of the most important messages in the report would be to convey to the oncologist that these were things that were somewhat far afield from actionable. We've published on this about what is the optimal way to report these complex molecular findings in tumors, and we and others agree that really there has to be a very clear tiered system in terms of clinical reports of molecular pathology that oncologists can readily translate into therapeutic actionability. For example, top tier would be a mutation, BRAF V600E, linked to an FDA-approved medication. Second tier would be perhaps mutations that are clearly associated with responses, but either perhaps not to an FDA-approved but an emerging agent, or perhaps an agent that's FDA-approved for a different indication or different disease type. A third tier, and these need to be carefully delineated in these reports, would be, for example, variants that are related to pathways linked to response, or variants not clearly associated with response. The talk we heard from Neil Rosen yesterday about the whole panoply of BRAF variants might fall into that third tier category because they haven't been correlated with clinical responses in a systematic way. And then fourth tier would be variants that probably are affecting the function of a gene, but unclear what we would do clinically about that. And then the fifth tier would be some of the ones, which actually includes two of the variants here, that are intronic, suspected to be deleterious in terms of gene function, but not entirely clear that they're affecting the function of the gene. So I don't know, did the audience get the reports at all, just so they know? But just so you know that this is not the report that a clinician would get, and that the clinicians and pathologists currently, and where the landscape of the field is, are working very closely together to try to make these reports as interpretable as possible in terms of the actual meaning, because the data is very complex. So on to P53. So P53, of course, the most common gene mutated in cancer. Currently not directly therapeutically actionable, just so that folks know there's, of course, a lot of interest in how do we target P53. There's three general strategies to target P53 in the current thinking. Number one is for tumors that have wild-type P53, the idea of reactivating that wild-type P53 through inhibiting inhibitors such as MDM2. The second class is mutations of P53 where there's loss of function that changes the metabolism or properties of the cell that might create so-called synthetic lethalities. So a P53 mutant tumor would be sensitive to a particular drug that a P53 wild-type normal cell would not. So those are two of the ways. And then the third way, P53 is a rather unique tumor suppressor because its mutations not only lose the normal function, but actually gain an oncogenic function. P53, if you put the mutant protein in a cell, it actually promotes metastasis and other properties. And so other strategies have come up to try to refold, in some cases, the protein structure of that mutant P53 to make it behave more like wild type, where it would then execute the tumor cell. And so those are the three approaches, none at the level of phase 3 trials yet, but the work goes on.
Well, that's excellent. Thank you so much for your comments, Leif. This is very helpful and good feedback for us for future tumor boards as well. Justin, do you want to comment on the role of immunotherapy, particularly in a tumor that might have multiple alterations, and the role of TP53?
Yeah, so that's a great question. And I think this is a good segue from the previous talk where Dr. Wu showed several papers looking at mutational load and responsiveness to immunotherapy, and really beginning with melanoma, and moving towards lung cancer, and then more recently in colorectal cancer, showing that as one increases mutational load, it seems like there's an association with responsiveness to checkpoint blockade. And in fact, it's now become a sort of an obligatory slide showing the TCGA data based on each cancer type. And we see that at the far end, so the cancers with the highest mutational load are cancers like melanoma, lung cancer, bladder cancer, and these are really the malignancies where we now have FDA-approved immune checkpoint inhibitors. Those are really the cancers that have high mutational loads. And then when we delve into those specific cancers, we find that there's a tremendous spectrum. So for example, as a thoracic oncologist treating lung cancer patients, we know that a smoking-induced cancer has a much, much higher mutational load compared to a lung cancer that arises in a never smoker. And that actually has clinical implications, because when we look at use of checkpoint blockade in smokers, response rates higher than it is for never smokers. In fact, response rates among never smokers are actually quite low, 3 to 4% in our experience. So I think the mutational load, this hypothesis, we're certainly seeing it clinically, but I do think it's important to emphasize that there are certainly patients who have high, it's not perfect. There are patients who have high mutational loads who don't derive benefit from these drugs. And it speaks to this concept of this neoantigen lottery. Just because you have a high mutational load doesn't mean that you're going to have one of those mutations that generates a neoantigen. It just increases your probability that you're going to generate a neoantigen.
Now, Justin, this patient has a P53 mutation. Does that increase the chances that she has a more mutated tumor?
Yeah, I think it's interesting because I look at these reports a lot. I think it's important to note that to begin with, comprehensive genotyping is standard of care in lung cancer. I think that's really an important point to emphasize, that patients should be having comprehensive genotyping in lung cancer. And looking at these reports, I would say we see a few more alterations than is typical for standard lung cancer. But at the same time, this is a fairly limited panel of about 100 genes. And all of the studies to date have mainly looked at mutational load using whole exome sequencing. So I think it's intriguing, and as was alluded to, having a p53 mutation, perhaps there's a higher mutational load here, but we don't know, because most of those studies used whole exome sequencing, and they were pretty small. So the RISV data that was published in Science last year that showed mutational load as being important in lung cancer looked at 34 cases total. So I think we have to remember that it's still small amounts of data, and we really need to then start validating this both in larger subsets and also using smaller panels, right? Though you can't really use whole exome sequencing clinically right now, so can we actually get a sense of mutational load with a smaller targeted NGS panel, and how large should that panel be to both be feasible but also give us a sense of mutational load?
And for the mutation load, does it matter as to what specific mutation it is? There might be something about certain mutations that cause more neoantigen than others.
Right. No, I think that's a great point. The data that I'm aware of in lung cancer was really focused on KRAS mutations. There's been a lot of emphasis on KRAS mutations. And we know that specific KRAS mutations so far really haven't given us a sense of prognosis, but the co-mutations with KRAS can. So there was interesting work published by MD Anderson last year showing that you can really subdivide KRAS mutations into 3 distinct buckets based on co-mutations. And it was the KRAS plus P53 subgroup that tended to have a higher mutational load compared to the KRAS plus LKB1 subset in that work. And so the authors hypothesized that may be the subgroup that's more responsive to immunotherapy.
So that's quite interesting, because we have this other gene that's mutated here, the NF1, which feeds into it's basically a KRAS activator.
Correct.
And maybe that plus P53 would be an indication that we have a high mutational load in this patient.
Exactly. So I think that's one of the reasons why I want to bring up that. And we do know that for NF1 mutations, 75% of the time they occur by themselves outside of the context of another oncogenic driver. But when they do occur with other driver mutations, it tends to occur with KRAS mutations. And with P53 mutations, sorry.
So what I would say that, in terms of molecular diagnostics and our panels that we use, they were really geared toward targeted therapy. And so we're still trying to kind of catch up to, really implementing immunotherapy. And, so we have a lot of these discussions internally in terms of how well do our platforms predict tumor burden. And we've looked at it, somewhat. And, what we do find is that definitely in cases with MSI, we do find a higher prevalence of mutations even with our 100-gene panel. How accurately do we predict that? I don't think that we know right now, but it seems to be even these relatively focused panels still provide some information. So what we're looking to do now is really try to expand our panels to have markers throughout the genome that we can better predict this and try to implement this as part of the routine care.
Excellent. So Justin, if you had this patient in clinic and you had access to all targeted therapies ever made, so in the perfect world, what targeted therapy or therapy combination would you choose for this patient?
Yeah, so I think it's important to go back to Leif's comment about how do we tier these alterations. And in lung cancer, the field is moving very quickly. And really, I talk to my patients, at least newly diagnosed patients, about 3 major classes of systemic therapies. Historically, it had been all chemotherapy. Really, platinum-based chemotherapy had been the standard of care for a long time. In the middle, the second major class is targeted therapy, which you're alluding to. And there are certainly several tier 1 genetic alterations where we know that using a targeted therapy is superior to using platinum-based chemotherapy. So for example, EGFR mutations ALK rearrangements, ROS1 rearrangements. Those I would characterize as really tier 1 genetic alterations. We also have some really emerging targets as well, targets where we have them in other malignancies. For example, BRAF mutations occur in about 4% of lung cancer, MET splice site mutations, RET rearrangements, NTRK rearrangements, where we actually are now starting to see responses, but not necessarily having FDA-approved therapies. So those are some of the alterations where if I see them, I'm going to pursue a targeted therapy in a patient who's newly diagnosed. The third major class, and this is really, I think, hot off the presses if people looked at the New England Journal of Medicine last week, is immunotherapy, but using first-line immunotherapy. So last week was published the findings of Keynote-24. This was a randomized phase 3 study comparing pembrolizumab, a PD-1 inhibitor, versus platinum doublet chemotherapy in newly diagnosed lung cancer patients. And here they used a biomarker selection strategy, so all patients had to be PD-L1 positive in 50% of tumor cells or more. I should note that 30% of lung cancer patients enrolled in that study met that cutoff. So this is a big piece of the pie. And what's notable is the pembrolizumab showed improvements in both progression-free survival and overall survival in that study. And so that has become the new standard of care for the subgroup of patients who are PD-L1 positive at greater than 50%. So for this patient, though, none of these alterations are in that tier 1 or tier 2. I would test for PD-L1, and if it was greater than 50%, I would pursue immunotherapy. If it was less than 50%, then I would pursue standard chemotherapy. And then as the patient progressed in therapy, if we gave chemotherapy first, I would certainly want to include immunotherapy at some point in our care. And then when we start getting into third line or so, we start thinking about, are there clinical trials that interrogate the pathways based on some of the genotyping data? And so I would be interested in, MEK inhibitors, for example. So there's some data looking in the pediatric literature showing that NF1 mutant patients have some responsiveness to MEK inhibitors. That also mirrors some preclinical data as well. So that would be something I'd be thinking about. But again, not as standard of care in first line.
So that's great. And I think you highlight a very important point that when we look at a report, there are two layers. Even if you find something that is actionable, the first is, can I act on it? But the second, which is equally, if not more important, is, should I act on it? And that looks at what's the current landscape. Should you abandon a standard therapy in favor of something that is potentially actionable, but you might not get the same benefit? So in any closing comments, when you see these reports in clinic, are there certain features that you really like? At MGH, we are a bit spoiled by that we get snapshot reports, but sometimes we also get genotyping reports from other institutions or other diagnostic companies. So are there key features that you really like when you're looking at a genotyping report? And Leif, you alluded to some of these points before.
Well, I think there's some consensus that you have to make a clear statement to the oncologist about what's actionable and what's not. But I'm interested to hear from Justin about what you think of that, versus commercial testing panels. Do you think there's a large variability in your impression about the sorts of reports you get, or do you think that the companies and the private enterprises have come together to make these as interpretable as possible to oncologists?
I would say many times the commercial companies try to make them interpretable, but I think many times are off the mark in that you'll get a list of 100 different clinical trials that one should consider. But then when you actually look at the genetic alterations that you're seeing there, it's not something I'm very excited about. And so I completely agree with you. I really like this, thoughtful tiered system and how we should really think. Just because you see a genetic alteration in a gene doesn't mean that that's actionable, it's relevant to the function. So I think those are some of the things that oncologists need to wrap their heads around. And I think that's one of the beauties of the Molecular Tumor Board, in that we have molecular pathologists, clinicians, all working together to try to interpret what can be very complicated genotype data, especially if you're treating, multiple different cancers out in the community. This could be something really difficult to try to digest.
We might have some questions from the audience about this, if there are any. Dr. Martino?
Oh, we've had a precision tumor board now at CI&J for over 3 years, and if you eliminate these tier 1 and 2 mutations, our data and others, I guess your data too, show about 30% of the time there is a actionable mutation. But what I haven't seen is what are the clinical results of those actionable mutations. Do you have any data on that?
I think that is a little bit the holy grail. I think that some of us, including our center, is trying to put together this data. I think that there's some disagreement about whether it needs to be done in a highly controlled setting for one gene or one variant or one drug versus trying to look at just a huge composite of data for outcomes. I mean, certainly certain studies have been published. Patients who go on a trial based on genotyping have a higher response rate than patients who might appear to be matched but did not go on a trial guided by genotyping. But these are very rough data. There are no large data sets to my knowledge, and I think it's going to take a little bit of big data to really answer that question because of the heterogeneity in the landscape of the reports, the genes, and the drugs.
Bruce, this would be a question as much for you in your capacity as editor-in-chief of the Journal of the Oncologist, as well as for this expert panel. If you're ever interested in getting a broad swath of the community oncologists who get lots of data, as you were obviously talking about, and get their opinion as to what really is helpful and what may be unhelpful, one of the thoughts would be, and Annie, this would be something for you and Bruce to talk about, is actually opening up in the Journal, the Oncologist, a section where you could actually have this kind of a tumor board published. And with you're already laughing, right? And then with the forms that you're describing, and Leif, I'm sorry we don't have them up on the screen, but that would be really helpful. And then to ask for feedback and through a communication just with a journal, letters, not just the editor published, but actually blog online. We certainly could give you direct feedback on that kind of a proposal if you're ever interested.
I think the panel is smiling because I think we all agree that this would be a very important contribution, and there's discussion about precision medicine clinic section in the oncologist where we discuss these things, and I think that would be very important for the community oncologist. Absolutely.
I think there are some interesting aspects to that. One is that certainly you can give comments back on what the importance or what's known about a certain mutation. Actually giving advice about how to treat any patient, I think, would be difficult. So I would like to ask Leif one other question. So P53 mutations have been associated, at least experimentally, with poor response to chemotherapy. Should that be taken into consideration? I'm not sure that probably doesn't get into the report, but should we be conscious of that when we're
Well, it's a fascinating question, and to some degree it speaks a little bit to the duality of P53 and this issue of that it's also a gain of function and a loss of function. And in breast cancer, I think, is an area that's my clinical specialty that's particularly either interesting or confusing in that there are certainly multiple published reports that in the setting of primary disease, responses to chemotherapy, clinical responses, are higher in the subset of P53 mutant patients, and that's been attributed to the fact that those patients have cell cycle deregulation that is more amenable to targeting with chemotherapy. On the other hand, not all of those studies have taken into account, and then that's been validated in various mouse models. But those studies really haven't necessarily all taken into account the long-term outcome of those patients, because you can imagine That it's not the idea whether 95% of the tumor cells disappear with the chemotherapy. It's a question about whether the other 5% are eventually going to grow out and metastasize and kill the patient. And I think that's where there is still some uncertainty in the field about whether p53 is going to be a strong, particularly chemotherapy predictor for that reason, because it also engenders, it may be higher responses, but also potentially engender more resistance.
Right. Very good. Thanks.
Could you also comment on Darren and Leif in terms of if you're seeing a molecular alteration, when do you get concerned that this actually might be a germline alteration? And how do you, what's the workflow in terms of informing the patient or the oncologist and intake in a genetics clinic?
Yeah, I think that that's a great question. It's a very complex question in that respect. Our testing is for somatic alterations, so we're a little careful in reporting germline. There's a number of considerations. One is patient consent. Has the patient consented for that type of information, because it's impacting not only that patient but the relatives of that patient and the offspring. There's clearly a number of genes that are associated with hereditary cancer predisposition syndromes that are in our panel that we can find mutations that have been previously reported to be germline. And so we have these databases that we can look into, and when we find what we think could be a germline, so we're testing off tumor tissue, so we don't know the answer to that. We can just postulate that it could be germline. And if we think that it is germline, what we do is we have a close contact with the clinician and discuss that result and whether it makes sense to pursue consent and really determine if it is germline by maybe getting a blood sample that we can actually determine that. And Leif will tell you that then you start bringing on a larger team of genetic counselors, and so it's just another example of really kind of a community-based effort.
I was just going to say that it's a little bit of an evolving area in the field. Number one, the question about if you're trying to assess the actual accuracy of the mutation calls in the panel, do you really need to compare directly to germline? So that's an issue that speaks to whether you're really giving the best somatic information you can without the germline. And then the second question, as Darrell alluded to, is what kind of complexities does it create in terms of the implications for hereditary cancer if you're unearthing genetic hereditary findings that the patient and their family may or may not be prepared for. And then there's also the technical question about if you're just looking at the tumor, whether you can distinguish between those two and what's the clinical workflow to do that in the cases where it's a possibility.
So in this case, we have a patient with a p53 mutation. Does that raise any
Well, in fact,
alarms?
3 of the 4 genes have actually been associated with germline syndromes. SMARCA4, NF1, of course, and p53 have all been associated rarely with germline syndromes, with NF1 being the most common, actually, but this variant not a common NF1 variant. So these are things that are not infrequent, and that's why it's an important area of discussion.
Question?
Yeah, a question for Darrell. So I'm curious how you decide what markers to add to your panel, whether you've added epigenetic markers, and also with the FDA now looking at regulating LDTs, what changes in your approach?
That's a very loaded question. I think that in terms of what is the composition of the panels, we try to focus on those that we think really have the most therapeutic, prognostic, diagnostic implications that will ultimately be important to our clinicians in guiding therapy for the patient. So, we work very closely with our clinicians in terms of what those alterations are that should be included in that respect. And so in that respect, it's always kind of evolving. And just recently, we went from 20 genes to 100 genes, probably just a few months ago. So it's expanding very, very quickly. You had mentioned LDTs and the FDA. The FDA has announced that they are going to start enforcing oversight of all laboratory-developed tests, which falls under our operations. That all the testing that we do are LDTs that we've developed internally and have clinically validated. And I think that landscape is still evolving and becoming clear. I don't want to get into too much conjecture, hypothesis of what might be to come. But I think that clearly there is some need to provide information to patients and advocacy groups in terms of what are the tests that we have, how do they perform compared to other institutions. I think that that's information that's lacking. I think that that's actually very important information for patients to understand when trying to select what institute to go to. We could argue as to whether FDA is really in the best position to regulate that, or are there some other mechanisms that can be put in place, kind of like what we call proficiency testing in the clinic, where there is an organization that has a panel of samples that they can then send across institutions across the country and have a standard, and as long as you meet that standard, then you are okay, so to speak, to implement that clinically. So, I think that I'm kind of a little bit on the fence in that regard. I think we don't want overregulation. It's going to stifle our development and our ability to be able to deliver this in ways that we think are really best for our patients and for our institution. But at the same time, I think that there is more. There's a lot of LDTs out there, and that we do need to understand, what are the differences and maybe some benefits and disadvantages.
Thank you, Darrell. This was an excellent discussion. We actually ran out of time with just one case. So we can save the second case maybe for the next time. I would like to thank the panel for the excellent discussion. This was the first time we're doing this. So if there's any feedback or comments, do let us know. But would really like to thank the panel for an excellent discussion. Thank you.